Good afternoon. My name is Dr. Gould. I'm a consultant in intensive care medicine in University Hospital Bristol, and I've been invited to talk to you on the role of HME, this is heated humidification, during mechanical ventilation for COVID. Conflicts of interest. I've been invited to present at this meeting by Fisher Paykel. This is to repeat a talk I delivered as part of a webinar in the UK in June of 2020 during our UK-wide education programme around COVID-19. I'm not being directly reimbursed for this talk, but we do use Fisher Paykel humidifiers in our 44 intensive care beds in Bristol. So going into COVID, we'd seen China and Italy's experiences, and we had our own guidelines being published. This one on March the 27th, where with regard to heated humidification and HMEs, the recommendation was very strongly that we should be only using HMEs in patients, but being aware that they are prone to blocking, so we have to change them frequently. In America, the Association of Respiratory Care made the same recommendations with regard to HME filters. And looking back in 2010, there was this important publication from the European Society of Intensive Care Medicine focused around pandemic flu, where high quality bacterial filters attached to expiratory port of ventilators were recommended, and high quality bacterial heat and moisture exchangers were recommended at the endotracheal tube mount. Heated humidifiers or ventilators should be avoided. This was reinforced in 2012, a more recent publication after the experiences with pandemic flu, where the suggestion was that active humidification should no longer be considered as the gold standard. Passive humidification is safe and simple, and HMEs should be considered first line for heating and humidifying inspired gas. This probably reduces staff workload and reduces the risks of cross-infection. So this advice going into COVID was to use HMEs solely. It's a pragmatic advice. The evidence suggested that they were safe and effective. There are resource implications in using them compared with accessing heated humidified circuits, and it was felt to be safer for staff. But there was a historic fixation on pandemic flu in coming up with these recommendations. So what is the evidence about the performance of HME versus heated humidification? Well, we know through multiple studies that they can be used over sustained periods of time, up to 7 days, with no loss of humidifying performance and no obvious increase in risks of circuit colonization. This meta-analysis, published in 2018, a Cochrane review, showed clearly that there was a lower incidence of circuit colonization with HMEs versus heated humidification. But one study, which is the most up-to-date study in 2006, I'd like to draw your attention to. This is by Laurent. It was published in Critical Care. And essentially 120 patients having mechanical ventilation for greater than 5 days were studied, comparing HMEs for 48 hours versus heated humidification. These, however, were newer dual limb servo-controlled heated circuits with no water traps. None of the previous studies I've described in this Cochrane review used this type of circuit. And this study very clearly showed the incidence of ventilator-associated pneumonia in the heated humidified circuits was considerably lower than with HMEs. And this gave recommendation to suggest that heated humidification was performing better than HMEs in this role. There's also this paper the same year from Moran, who looked at the use of HME compared with heated humidification in patients with ARDS and showed clearly increased compliance, increased resistance, and increased plateau pressures with HMEs, also increased dead space and increased work of breathing during weaning. So he also felt that HMEs were less suitable for these types of patients. We've known for a long time, all of the previous studies show this, that airway occlusion is a problem with HMEs, and hence recommendations are that they should be changed probably 24 to 48 hourly in an ideal setting. Within a few days of the COVID becoming an issue in the UK intensive care community, we started to see safety bulletins being published from the Faculty of Intensive Care Medicine. This one, poor ventilation occurred in patients who were mechanically ventilated using a dry circuit with HMEs. Another publication the next day, dry sputum and secretions in ventilated patients causing endotracheal tube occlusion when a dry circuit is in use. So on the 3rd of April, within the first sort of 10 days of intensive cares being subjected to large numbers of patients, recommendations from our parent organizations suggested that cast formation and plugging can affect dry circuits, and we should be considering using wet circuits for these types of patients, but staff should be in full PPE. So the advice to use HME up to this point was very strong, but we had probably not really seen the true risks of prolonged ventilation. We were now ventilating a lot of patients for prolonged periods of time. There's issues around the terminology of HME, HMEF, and bacterial filters, and we've not really seen the evidence of the improvements in heated humidified circuits over the last 10 years. The filter type is an issue, and I'd like to focus on that now. So the hygroscopic filter at the bottom is essentially the ideal filter for humidification, but it runs a higher risk of pneumonia because as it gets wet, its filter qualities deteriorate considerably. The hydrophobic filter at the top has a reduced incidence of pneumonia, but they block more frequently. So when we want to understand HMEs, we need to be very precise with what we're talking about. And essentially, the ideal filter for humidification is a hygroscopic filter. And you can get HMEs that are purely HMEs. They have poor filter qualities. And this is to allow them to have low resistance. As you start to use hydrophobic filters, which are pleated to improve the filter quality, they are more prone to blocking. So HMEs that are hygroscopic would be better for long-term ventilation, as the majority of complications associated with HMEs, thick secretions, endotracheal tube occlusion, increased resistance, occur predominantly with hydrophobic HMEs. The newer HMEs available also include now electrostatic filters, and these are probably the optimal viral and bacterial filtration systems. And so a better understanding of the individual quality of filter design is important. And in an ideal world, you would probably put a hygroscopic filter at the catheter mount to optimize the humidification of the circuit, but still put a viral filter, perhaps an electrostatic filter, at the expiratory port of the ventilator. We shouldn't be using the hybrid HMEFs, which are really designed for use in theatres and not suitable for long-term ventilation. With regard to the filtration property, we need to have some understanding. They are published, and essentially the expiratory limb filter test using bacteriophages, and most proper expiratory limb filters will have an efficacy of 99.99%. The bacteriophage used to test them is 0.027 microns. It is between 0.85 and 0.1, so it should easily cope with COVID. Within the practice in my unit in Bristol, we use end expiratory filters for viral protection, and to improve their efficacy, we keep them as dry as possible by using dual-limbed heated circuits. They're designed so that the exhaled humidity diffuses through the wall of the expiratory limb. The actual bacterial filter is electrostatic, and that allows it to be optimal for filter quality, but is hydrophobic to reduce the absorption of water to prolong its life. And they're also double walled to have extra insulation so that they don't condense. So all of the target is to keep your viral filter as dry as possible in the expiratory limb. The electrostatic filter has the advantage of requiring less material, so it's to trap pathogens, unlike a pleated filter, so therefore there's reduced resistance to flow, but it's not an HME. And so by the 13th of April in the UK, we had very strong support, which was being reinforced from Europe, that there is strong consensus to use wet, not dry circuits. This advice also changed in America to use dry, heated humidified circuits and move away from HMEs. So the lessons from the past, essentially this is not pandemic flu, but there was evidence from SARS and the use of PPE from Canada, which we probably ignored, to be honest. This study from Canada in 2004 shows the way in which healthcare workers became infected with SARS over sort of 7 to 8 days from the onset of the infections are hitting the ITU. Respiratory therapists, doctors and nurses were all affected. But what they learned here was that the high risk episodes were interactions with intubation, with non-invasive ventilation, but nurses that were using high frequency oscillation circuits, which were popular in that time, using heated humidification, had a very low incidence of infection. And very clearly they said the addition of bacterial and viral filters on exhalation valves of all mechanical ventilators is important, together with wearing PPE. Within the UK, there is a summary of staff becoming infected. There were no anaesthetists or intensivists identified. And in the nursing staff that were infected in the UK, none were described as intensive care nurses. It's likely that intensive care areas know how to use PPE, and so it's safe to do these airway type procedures in full PPE. That's what we've learned. So in summary, I'd just like to say the recommendations for HME is historic and not evidenced against latest developments in heated humidified circuits. There's a lot of confusion over the terminology of HME, HMEF, and bacterial and viral filters. And so it's very important that the guidelines are precise and specific when using this terminology. Thank you very much.